Good afternoon. Welcome to the Justice Center Summit, Spotlight on Prevention Best Practices for Responding to Medical Emergencies. This session is being recorded. You will get a copy of the slides, and this session will also be posted on the Justice Center website. So fear not, if you have to step off for a minute or two, you'll always have an opportunity to see this again. We will be asking questions during the session. If you're not opened it up yet, please do open up the webinar chat. There's been some helpful information that WRI has already put in, but that is a place where if you want to ask questions, that you can ask questions. As a webinar participant, everyone is off camera and muted, but we will be monitoring the chat and we will ask questions. After all of our sessions, we will be sending you an evaluation form, and we hope that you will take the time to fill it out and let us know what you'd like to see next year. So a little Zoom housekeeping before we kick things off. As I said before, look at the chat. You'll get helpful information, links, and materials throughout the session, and it's also the place to put your questions. You can also click on closed captioning, and I should have mentioned this at the beginning. If you're new to Zoom and you're not seeing these toolboxes, just scroll down to the bottom of your screen and they should appear. But you can also get closed captioning available. So once again, the sessions are being recorded. You will receive a copy of the slides after the sessions. So without further ado, I'm going to turn it over to Tracy Sosa and Brandy Young to present.
Good afternoon. Thank you so much, Davin, and thank you all for joining us today for this presentation on the Justice Center Spotlight on Prevention, Best Practices for Responding to Medical Emergencies. I'm Tracy Sosa. I'm one of the supervisors in the Justice Center's Prevention and Quality Improvement Unit. I've been with the Justice Center for nearly 5 years now. Prior to that, I have about 17 years of working in the field with people with intellectual and developmental disabilities, most recently in the residential setting. Brandy, would you like to introduce yourself?
Thank you, Tracy. Good afternoon, everyone. My name's Brandy Young. Brief background about myself. My educational background is in school counseling and mental health counseling. I worked as a behavior intervention specialist and intensive behavior coordinator for 8 years at ARCs in upstate New York prior to coming to work for the Justice Center in 2019. Since arriving at the Justice Center, I've worked solely with the Prevention and Quality Improvement Unit, and I will be celebrating my 4-year anniversary next month.
Thank you so much. Okay, so let's dive in for what you've come to, to hear about today. Today's presentation, so first of all, actually, before we dive into the presentation, we do have a poll question that we would like for everyone to answer. So if we can have our poll pop up, we'd like to know who's on the call with us today. If you can let us know if you're affiliated with one of the state oversight agencies, whether that's OPWDD, the Office for People with Developmental Disabilities, OMH, the Office for Mental Health, the Office for Addiction Supports and Services, Office of Child and Family Services, SED, DOH, or if you're not with one of the oversight agencies, just let us know that as well. We'll give everybody just a minute to respond here. All right, so it looks like, by and large, most of the folks on the call today are affiliated in some way with OPWDD. It looks like 51%. We have a number of people from OMH with us, 22%, 8% with OASIS, 6% with OCFS, smaller numbers from SED or DOH, but we're glad that you're with us. And then about 27% of the folks that maybe are not affiliated with a specific oversight agency, maybe we're family or advocates or some other relationship. But we welcome you all for joining us today. We appreciate you being on the call. So now that we know who's on the call with us, let's dive into the presentation. First, we will start by providing a general overview of some of the Justice Center abuse prevention resources. Currently, the Justice Center has 9 different spotlight on prevention toolkits, as well as prevention resources like agency self-assessments and best practices for creating abuse-free environments. In just a moment, Brandy's going to take some time to show you how to find those resources so that you can reference them after the presentation. After that, we're going to talk specifically about one of our newest spotlights on prevention, toolkits, the best practices for responding to medical emergencies. Following the presentation, we hope that you will have a greater understanding of the information and resources needed to support an effective response to a medical emergency. But before we do that, we're going to turn it over now to Brandy, who's going to show you how to access some of the Justice Center resources.
All right. Thank you, Tracy. So before we, like Tracy said, before we begin talking about best practices in medical emergencies, we'd like to provide you with an overview of all the prevention resources in our website. The Justice Center currently has several spotlights on prevention toolkits that can be found on our website under the Prevent Abuse tab. I'm going to forward us to the next slide so that Lisa, if you could please click on the Justice Center hyperlink to bring us to the website. Bear with us while this comes up. All right, so this is our landing page when you come to the Justice Center website. Our resources that are included in this Prevent Abuse tab were developed on topics that the Justice Center was receiving and reviewing high-frequency reports on. We developed these resources to bring attention to these issues and to offer resources to help reduce the recurrence of similar incidents. While these resources will continue to grow and be updated, we want to make you aware of them and to share with your agency and other providers. So as Lisa showed you on the screen, once you click that Prevent Abuse tab, this next page will come up with our various resources. When we scroll down, the first ones to come up for Spotlight on Prevention have to do with our agency self-assessments, best practices for abuse-free environment, and code of conduct. Each of these topics include links to prevention products that can assist agencies in establishing policies and procedures and to help create an abuse and neglect-free environment. They can help with preventing people receiving services from leaving programming without consent and to train staff on the code of conduct. Now, if we continue to scroll down the page, next we'll come to the Spotlight on Prevention toolkits. So each of these tiles, purple tiles you see here, you are able to click on and it'll bring you to the corresponding spotlight. Each of the current spotlights we have are on body checks, dangers of being left unattended in vehicles, dangers of caregiver fatigue, dangers of intestinal obstructions, responding to medical emergencies, reducing the use of restraints, securing wheelchairs and vehicles, maintaining professional boundaries, which is our most visited prevention resource, and our newest, that was just released last week, best practices for effective medical care. Shout out to Tracy, because she did a lot of work on that, so we're all very excited to have that out and available now to providers. Each of these spotlights, if you were to open one up, they have a similar outline. It'll begin with an overview of the topic, then it can move into case studies. So we included these as an aid to staff training and to help provide examples of situations that we've encountered through our work and to help stimulate conversation on how to prevent it from happening and to learn where mistakes happened. Steps agencies, staff, family members, advocates can take to reduce and address the issue that the toolkit's addressing. And lastly, we include resources, forms, sample policies, fact sheets, things like that, that agencies can pull from and use if they want, tweak, make it work for your agency. So that's all that's generally included in our spotlights. Real quick, we're going to open up the responding to medical emergency. So Lisa, if you could please do that. Just to show you what it would look like once you access it, it'll bring you to the specific page here, and if you scroll down on the left, you'll see that each section of the spotlight is broken up. So if you want to just jump to a section, you can do so by clicking on the left. Otherwise, by just scrolling down, you'll be able to go through each of the sections. This is just a brief snippet of the actual toolkit itself. Once you go down to the bottom of the page, you'll see here there's hyperlinks to download the full toolkit itself, and each individual section can also be downloaded in case you just wanted one part of it to use at your agency for, policy, training, whatever it is you might want to use it for. So this is the setup for most of our current spotlights. We are always updating, we are always revising, trying to make them more accessible, easy to read, easy to follow. So we always appreciate feedback on our products. So please feel free to, let us know what you think of them. But otherwise, that was mostly what I wanted to show you regarding the current spotlights and how to access them on our website. So Lisa, if you'd like to go ahead and close that out, thank you. All right, I'm going to move us forward here, and we're going to do a quick poll, because one of the goals of the Justice Center is to make agencies more aware of the resources we have. So I would like to conduct this poll at this time to determine what resources and spotlights those joining us today may have already reviewed. So if you guys could please take a look here at questions 1 and 2, and any of these resources that you have accessed prior to joining us today, if you could please click on them to let us know which ones they were. And just note that there are 9 possible responses, so please scroll down to access all options. And we'll go ahead and give everyone a minute to fill that out. All right, so according to those who responded, Code of Conduct, not a surprise that that's the most accessed. Next, we have corrective plan guidance. Great. This is all great information for us. We'd like to know what people are looking at so that we can always be, like I mentioned before, updating and making sure, our resources are applicable. And in terms of spotlights, it looks like pretty even between professional boundaries and body checks. So that's wonderful to see. And I'm glad to see that each one got clicked on. So this is good. Others have been able to see our products. So that's exciting for us. So thank you everybody for taking that poll. Okay, so moving on, the last thing I wanted to share before turning it back over to Tracy to jump into responding to medical emergencies is that in addition to our website, the Justice Center has a LinkedIn page where all of our prevention resources are shared. This page is helpful to access because it's up to date on what's going on at the Justice Center, including the new spotlights, like the one I mentioned before that had just been released, summits like the one everyone's attending today, other events, job opportunities. So please feel free to follow us to stay up to date on what's going on here at the Justice Center. But other than that, at this time, I'm going to pass it over to Tracy, and we'll start our discussion on best practices for responding to medical emergencies.
Thanks. I just want to point out one thing because I know some people have joined late. We get it. You're in human services. Something came up. There's a question about how to access the prevention tools, which Brandy did. And I'll just make this announcement again. We are recording this webinar. It will be available on our website, hopefully next week even. And so then you can go see it. But you can access all of our prevention tools if you go on the Justice Center website and click on Prevent Abuse. Take it away, Tracy.
Great, thank you, Davin. So now we're going to stay focused on the topic of the spotlight on prevention for responding to medical emergencies. This toolkit was developed in response to trends and concerns that we saw involving numerous cases involving an incident that had a poor emergency response that led to fatal or near fatal outcomes. So we created the spotlight to offer recommendations that could help provider agencies be best prepared for handling these types of situations. Okay, so to give you a little bit of background, the Justice Center developed this spotlight for responding to medical emergencies, again, based on trends and concerns that we saw from the field. For example, back in 2021, the Justice Center substantiated nearly 250 cases involving inadequate medical care. So the substantiations were a combination of what we call Category 4 substantiations. These are substantiations against agencies for failing to take steps to mitigate risks. So for example, there may have been a lack of policy, a lack of staff training, a lack of administrative oversight that led to an abuse or neglect incident. Or we also had substantiations against individual staff members themselves for perhaps failing to follow policy or failing to follow plans of care. The issues that we saw vary and still do vary by program type. In OPWDD, for example, we may see more cases involving people who are medically frail, who rely on staff to help provide them maybe with their medications, to take them to medical appointments, to provide medical treatments. Whereas in OASIS, for example, we may see more issues related to overdoses or concerns with staff not having access to or administering Narcan. Regardless, cases come from all of the state oversight agencies. We did ask the poll question before, wanting to know who is joining us today. It helps us to know who our audiences. Also, when we develop our spotlights, we really try to make them applicable to all the state oversight agencies, recognizing that the vast majority of trends and concerns that we see do impact all of the oversight agencies. When we looked at all of the trends, issues, and concerns when we started to develop the spotlight, we realized that the issues fell into two really large buckets. The first bucket was delays in either recognizing or responding to a medical emergency, and the second bucket was failing to provide effective medical care. The concerns related to delays in recognizing or responding to medical concerns involved a number of issues. We saw cases where staff discovered an unresponsive person, and instead of calling 911, they called a supervisor or they called a coworker to come and look at the person to help confirm whether or not they should call 911. We saw concerns where staff didn't initiate life-saving interventions such as CPR when they discovered someone who was unresponsive because maybe they weren't comfortable doing it, maybe they weren't trained on CPR, or maybe they weren't prepared that medical emergencies aren't always neat and tidy, and they were uncomfortable because maybe the person had vomited. So we saw lots of issues there where staff's response led to a lack of a timely medical intervention. We also saw concerns where there was a lack of intervention, sometimes due to things like a breach in supervision. We've seen a number of cases where something like overnight bed checks weren't provided, and when staff checked on a person, they found them unresponsive and maybe found that they had passed away and had been passed or deceased for quite some time, but no one knew it because they hadn't been checked on. And some of the state oversight agencies, we do see there's a relatively young workforce. Some of the staff working may not have a lot of life experience. Maybe they've never had an experience where they've been around somebody who's medically frail, much less having to take care of someone who's medically frail. Maybe they've never seen an unresponsive person or had to respond to a situation and provide life-saving intervention. So these are all things that can impact whether or not a person receives timely medical intervention. So the other issue that we saw was related to providing effective medical care. And as Brandy noted, just last week, we released a spotlight on prevention related to best practices for effective medical care that you can access on the website. And here the trends and concerns that we saw were different from the failure to provide or respond to a medical emergency. These were things like basic medical needs not being cared for. Maybe medications weren't administered as required. Perhaps there was a failure to ensure that people attended medical appointments. Maybe there's concerns with things like failing to turn and position people correctly or provide care for like a G-tube and just ensure that people are getting the care and treatment that they deserve. So the spotlight for responding to medical emergencies, like Brandy said, many of our spotlights have a fairly similar format. We're trying very hard to ensure that we're providing both information and tangible resources that providers can use. We'll talk more in detail on the following slides, but as Brandy just showed, how to access the Justice Center website to be able to review the full toolkit. We'll just do some highlights during our time today. Generally, our toolkits will provide an overview of the issues or concerns. We'll provide a little bit of background for providers, and then we'll also have specific guidance or recommendation for staff and agencies to follow. We love to include as many resources as we can. Many of our state oversight agencies themselves have great resources that we try to link in our toolkits. And then we also provide, could this happen in your program, training scenarios with different teaching and training scenarios to help agencies recognize where they may have possible risks or concerns in their own programs. So before we talk about this slide, we have another poll question for you. We'd like to know whether or not those of us who are joining us on the webinar today have ever had to call 911 or respond to a medical emergency. And you can check all that apply. This is another multiple choice poll. So we'll give you guys just a minute to let us know about your experience either calling 911 or responding to a medical emergency. Okay, so it looks like we've had lots of people having to respond or call 911 because somebody had a fall, closely followed by somebody having a seizure. Looks like we also have high numbers for things like head injury or somebody being unconscious, followed by cardiac events, choking, and bleeding. So it looks like there's quite a number of people here joining us today who have had experience either having to call 911 or respond to a medical emergency. So we appreciate you guys sharing your experience. So the best way that we feel that agencies can help prepare staff for responding to medical emergencies is to ensure that staff can recognize a medical emergency and recognize situations that require an immediate medical intervention. Not only that, but which situations require an emergency response, such as calling 911 versus taking someone to an emergency department. In this toolkit, we do have a resource called a medical emergency at a glance chart that Brandy is actually going to show you a little bit later in the presentation, that provides a really nice visual guide for staff to recognize which kinds of situations might require a call to 911 versus situations where a person can go, like be driven to an emergency department, for example, or situations where it just requires a follow-up phone call to an RN or maybe a primary care physician. But what you'll see throughout this toolkit is guidance for agencies to have policies in place for staff to call 911 independently, immediately at the first inkling that there's an emergency without having to get supervisor approval or contact a nurse first. Staff should be supported to call 911 as soon as possible for medical emergencies. We want staff to be empowered to call 911. As we've mentioned previously, we've seen a number of cases where there's been a delay in contacting 911, which led to a delay in a person receiving medical care. And in medical emergencies, we know that sometimes every single second is critical. So here at the Justice Center, the slogan that we like is "Don't delay, call right away." So next, we're going to talk a little bit about best practices in 3 different areas for policies, environments, and training. We're going to start with policies. As we mentioned, we really want agency policies to instruct staff to first call 911 for any emergencies. And you're going to hear us say that again and again throughout this presentation and really emphasize it because it's so important. Having policies that support staff's decision to call 911 before anyone else, like having to call a supervisor or an administrator, can really be crucial in getting the necessary medical care for the people that we all support. Another best practice that we see and that we recommend for agency policies is to outline training requirements for staff. In this case, we're referring specifically to training requirements for things like CPR, first aid, and any other type of training that speaks to preparing staff to handle emergency medical situations. Ideally, any policies or procedures are also going to address requirements for refresher training. The refresher training is critical in keeping staff skills sharp. There's the old adage, if you don't, ride a bike, you forget, right? So we want staff to be able to practice their skills so that they don't lose them. Hopefully you've been fortunate enough not to ever have to administer CPR to anyone, but if you didn't have refresher training, would you remember how to do it? As I referenced, I used to work in the provider field. I haven't been trained in CPR for a couple of years now, and I'm not entirely sure that I remember what the proper ratio of chest compressions to rescue breaths, for example, are. So it's important that staff have the refresher training so that they can remember those things. We also know that sometimes training changes, and the way that something was taught years ago is not the same way that it's taught now. So it's really important that staff continue to receive training so that they're trained on the latest or most current types of interventions. During our audits, it's not uncommon to see lapses in staff training. Sometimes we see challenges with staff training documentation being lost, so we also recognize that it's important for staff to have a good system for tracking and maintaining staff training records. A third best practice is to identify timeframes for on-call supports to respond to staff who call with medical concerns, and to also provide guidance for staff for what to do if they don't receive a response. Again, staff should feel empowered to contact emergency services or to elevate concerns to administrator if they don't receive a timely response, and agencies should support those decisions. We've seen some excellent agency policies that provide very specific guidance for staff to follow if they're reaching out to a nurse or to an on-call support with medical concerns, for them to keep calling until they get a response, or after a certain period of time for them to elevate that concern either to another nurse, to an administrator, or to call 911 if they don't get a response in a reasonable time. We've also seen some really tragic outcomes when there hasn't been an identified time frame for RNs or other on-call staff to respond to staff who are reaching out to them with medical concerns. We've seen cases where staff have called on-call supports and left a message, not realizing that that person was on vacation and somebody else was covering for them, or not realizing, in one instance I can think of where a nurse had resigned that morning and staff weren't aware of it. We've also seen cases where staff have done things like send a fax to an RN, but never receive a confirmation that anybody had received the fax. So again, it's really important that policies identify timeframes for staff to receive a response or to know what to do if they don't receive a timely response, and to elevate issues or concerns. So next we'll talk a little bit about staff actions. If staff have been prepared for how to recognize and respond to a medical emergency, hopefully they will be able to take the necessary and appropriate actions to address the emergency. So again, we're not going to stress this enough. First, call 911. Don't delay, call right away. We want staff to contact 911 as soon as they have the slightest inkling that there might be something wrong. And we'll take a moment here just to reiterate what we've mentioned before, that staff need to be trained to recognize situations that require an emergency or immediate medical intervention, and then also to be empowered to contact 911 as soon as they encounter or suspect an emergency. Secondly, in the event of an emergency, we want staff to clear the area as much as possible. If there's another staff, if possible, have them help remove if there are any other people receiving services in the area. We want to ensure that there is a clear path for any first responders to be able to access the person who's in need. We don't want to delay care any further by not having providers, not having the first responders be able to access the person receiving services. We also need to make sure that if there are other people receiving services in the area, that they continue to be supervised during the crisis. We also want to, as much as possible, not expose them to any trauma. So if there's another staff available or anyone who can assist, try and remove the other people receiving services from the area, ensure that they're supervised so that we don't have, again, any potentially traumatic situation for them to witness, or for there to be maybe an escalation of another issue or concern. As much as possible for staff to remain calm. If staff can stay calm and keep a cool head in the midst of an emergency, it's going to help ensure that the people around them also stay calm. It will help ensure that staff are able to follow their training and ensure that supports are provided as needed. Of course, staying calm, it's always easier said than done, right? Some of this is dependent on good staff training, which we're going to talk about in one of the next slides. But definitely a calm response helps to ensure a good response. Last, we want staff to begin life-saving procedures immediately. So this can be initiating CPR, it could be administering Narcan, or administering abdominal thrusts. But as soon as staff recognize that there's an emergency, if there's an intervention that they can provide to help that person receiving services, they should do so. Okay, so now we'll talk a little bit about staff training, but before we do that, we have another cool question for you. Does your agency train staff using mock emergency drills? If you could just take a quick moment and let us know yes or no. Okay, so it looks like we've got 47% saying yes, their staff, their agency trained staff using mock emergency drills, and 53% that don't. So that is good for us to know. We ask this because we do think that it is an important and a best practice related to staff training. We say this because we think no matter how prepared that you think you are to handle an emergency, we can never truly predict how someone is going to respond. So if agencies are conducting mock drills using realistic situations and then providing timely feedback to staff on how they handle the emergency or the mock emergency, we feel that this can really provide staff with important tools to help them stay calm and respond appropriately during an emergency. As mentioned when we were talking about policies, We also think it's important to ensure that staff are trained in CPR, in first aid, in the administration of Narcan upon hire, and that they also receive refresher training as needed to ensure that staff are equipped with the skills needed to intervene in an emergency. We recommend for providers to use realistic training scenarios. So for training on CPR, for example, consider using weighted dummies for staff to have to move. We see many cases where people are discovered unresponsive in their bed, and staff don't move them to the floor to begin CPR. But if you've never practiced what that is like, or had to move someone who's heavy, for example, you might, have a panic response to that. We would also want staff to practice administering CPR using a backboard. Again, it's important that people are on a hard, flat surface. Most importantly, we want staff to be prepared that medical emergencies don't look like they do on TV, for example, right? So medical emergencies can be messy. They can be scary. There can be bodily fluids involved. There might be a lot of blood. People might vomit. People might be incontinent. And we've seen cases where staff had a freeze response to that because they just weren't prepared for it. So as much as possible, just prepare staff for what that could potentially look like. When it comes to staff training on fall protocols, what we really want to emphasize here is training staff not to move somebody after a fall. So this is something that also can be incorporated into mock drills to further reinforce that concept. We recognize staff have very good intentions to help people after a fall, but what we've seen happen in many cases is that a person's injury is exacerbated after a fall when someone tries to help them up. With respect to staff training, we recognize there are many factors that may contribute to how staff are trained, but to the extent possible, we feel it's best for staff to receive in-person interactive training to allow for participants to be able to ask questions to the trainer, and for the trainers to also really be able to assess how well staff are understanding the training content. Finally, staff also need to be trained when they are supporting people who may have advanced directives for end-of-life care, such as orders for do not resuscitate or do not intubate, or if they have medical orders for life-sustaining treatment. These things could potentially impact how staff respond to a medical emergency for those specific individuals. All right. So another poll question. For this question, we want to know whether or not your agency provides nursing supports. So if we could just take a brief moment here and have people respond to this quick yes or no poll as to whether or not your agency provides nursing supports. And 88% of those who are with us today work for an agency that provides nursing supports. Wonderful. That's great for us to know. As we mentioned earlier, we had discussed that we do try to make our spotlights on prevention as applicable as possible to all of the different state oversight agencies that are under the Justice Center jurisdiction. We do acknowledge and understand that there are some agencies under our jurisdiction that do not provide nursing supports and are not required to provide nursing supports. Therefore, our toolkit does provide some guidance for those agencies to help ensure that they also have the tools that they need to help ensure that staff are trained to respond appropriately in a medical emergency. So for agencies who aren't required to provide those nursing supports, we do still emphasize the importance of having policies for staff to be supported and empowered to contact 911 immediately upon the first indication that there's a medical emergency. We want to ensure that the policies support staff to call 911 without having to go through a manager, a supervisor, or an administrator first. We also want staff to be trained to recognize a medical emergency. So again, to ensure that people receive a timely response to a medical emergency, staff have to first recognize that it's an emergency. So a little bit later on in the presentation, we're going to show you the medical emergencies at a glance chart that I had also referenced on an earlier slide that can help staff recognize situations where a 911 response is needed versus maybe a call to a primary care manager or someone else. Similarly, we want to train staff to recognize signs and symptoms of illness. to recognize when somebody is ill or beginning to decompensate. So again, they can link them with medical care at the earliest possible opportunity. For managers, staff, or administrators who may be the people receiving those after hours, weekend, or on-call, other calls at other times outside of regular business hours, when staff are contacting them about a medical concern, we want them to understand that they need to direct staff to contact 911 right away. So some of this goes back to training staff to recognize medical emergencies and illness, but if you're being contacted out of concern for how someone is presenting, whether it's somebody has shallow breathing, they're just seeming off, maybe they're turning an odd color, we want those people who are receiving the phone calls to tell staff to hang up and call 911 right away. As a best practice, whenever possible, give staff the tools that they need to respond to a medical emergency and have them trained on first aid and CPR upon hire. And then, as we mentioned earlier, the importance of providing refresher training, ensure that there is some sort of refresher training provided to them. Okay, and at this point, I'm going to turn this presentation back over to Brandy.
I have one quick question that came up during this last session. With regarding your advice not to move people after a fall, is that for like every single fall or those that appear to be, the most severe in nature?
So I think the general guidance is if the person is not able to get up on their own, then we shouldn't be helping them to get up. So
thank you.
All right, so we're going to move on to 2 slides. The next 2 slides are actual tools that we developed that we hope will be used as a reference guide by staff and agencies. The first is our column chart, which you see here. The idea behind this is to establish a coordinated response to an emergency, so people already know what their roles are before an emergency even happens. So we've identified 4 distinct roles for staff and encourage staff to be assigned to these roles upon beginning their shift. To start, we have C, the communicator. So this person is going to be responsible for meeting emergency personnel upon their arrival to the program and sharing important information about the situation to them. They'll also be responsible to locate and provide the grab-and-go binder to EMS. And we'll make any necessary internal notifications about the situation. Later, I'm going to go into a little bit more detail on the grab-and-go binders, so we'll have some more on that later. The next is the assistant, so A. The assistant will help the leaders to keep the person in crisis safe. They'll be responsible for bringing any emergency and first aid supplies that may be needed to the area where the person is currently in crisis, and ensure that only essential staff are in the immediate area. So they're going to help keep the area clear and the person safe. Next, we have the leader. So the leader is the person who's going to be staying with the person in crisis and perform the life-saving procedures as directed. They would be the one responsible for providing CPR if that was necessary, and to model calmness for everyone else involved. Again, why we emphasize the mock trials to try and help people learn how to be in a situation that it can be intense and stressful and uncertain and still be able to present a calm exterior and help their coworkers in getting through the situation and the other people receiving services. And that's where the M, the milieu manager, will come into play. So this person would be directing other people away from the situation, including other people receiving services. Obviously, if someone's in the middle of some emergency, having others around them seeing that could be traumatizing to them, and they might get in the way of supports to that person in crisis without intentionally doing so. But we do find that having someone assigned to this role is important because they would also be ensuring that the access to the situation, the crisis, is clear debris, snow, ice, as Tracy mentioned before, so that EMS can get to the person as quickly as possible. We want to recognize now, we do understand that what we have here is an ideal staffing pattern in that many programs are not lucky enough to have 4 staff on at all times. So we do encourage agencies to look at these roles, look at these responsibilities, and review their staffing to see how they might be able to make these roles work with who's on and who can support in these situations. All right. Next, we're going to talk about some best practices related to the environment of your program. One of the first things we recommend is posting a hierarchy of needs reference guide in areas that are frequently traveled by staff. We've developed a version of this guide for this toolkit, and we'll, again, review it a little bit later here. But the main goal of the guide is to provide staff with an easily accessible reference. So when to contact 911, when it might be okay to wait, when to contact nursing or on-call or the person's primary care doctor. And it will provide a nice visual for them to be able to determine that information quickly. Some other considerations for best practices related to the environment are placing things like breathing masks, gloves, crash carts, anything that typically you might need in an emergency in an easily accessible place. We all know there's restrictions to where things can be put to make sure everyone's safe on a regular basis, but having those things easily accessible, staff know where they are. That's another important thing that we've seen. Staff are directed to go get something and they don't know where it is. So making sure staff are aware of where to find these items and having them easily accessible is something we would encourage for the environment. And the same would go for Narcan. And if those who aren't familiar with Narcan, it is a life-saving drug that can reverse the effects of an opioid overdose. We can't stress the importance of having that drug available to staff and the people in care. At this time, I do want to take another poll question really quick just to see who on the call today. First, does your agency have Narcan, and is it available to staff to use? And if so, has staff been trained on its use? So if everyone could go ahead and select yes or no from questions 1 and 2, and we'll give it a minute and see what our results are.
While people are answering, there's a question that came up that I'll just answer. The question was, are there regulations for OPWGD programs about Narcan and where to process, provide, store? That is really a question that's most appropriate for OPWDD because we don't do regulations for programs to follow.
Let's see. Does your agency have Narcan available? So majority of those joining us today, it appears they do not. And were staff trained on use of Narcan? Looks like those who answered yes to does the agency have it, it's pretty even that the staff were trained on its use. So that's good. That's good to see. We encourage agencies to have this trained staff. It's a life-saving medication, and making sure staff are knowledgeable on its use, where to find it, is all very important to the safety of those in care.
Brandy, I just want to emphasize enough. You said earlier having Narcan available is important for everyone, right? Whether or not you're a substance abuse provider, anybody at any point in time, you never know, might need this drug, right?
Yes,
Okay.
yes, absolutely. And, as much as we hope to never be in that situation, it doesn't hurt to have it available. Even for the people outside of the people we support, emergencies happen all the time, and it's always good to be safe than sorry. So, but yes, thank you, Davin. So as I mentioned before, the grab and go binders. So this will be the last thing that we're going to discuss related to the environment. And I'm going to proceed to the next slide because that'll go into a little more detail here. So grab and go binders, many agencies might be familiar with this concept, but it was something that from our work in our various backgrounds, I said ARC, these were something that you might see. Usually we'd like to see them created upon admission of the person so that it's already available for staff as they're getting to know a person, because in an emergency, if they haven't known the person very long, or even if they have, they might not be able to recall the information or might recall incorrect information. So it's safer to just have, something already outlined to include emergency contact information, diagnoses, medications they're currently on, allergies they have, anything that would be important for an emergency personnel person to know without being too bogged down either. You want to make sure it's a reference guide that they can review quickly and apply effectively. The use of grab and go binders can help ensure the emergency personnel receive all the information they need. Again, these situations can be very stressful, and we here at the Justice Center understand that, and that's why we create these types of guides and supports to help mitigate any stress or oversights that could occur during an emergency. So we hope that some of the information we're sharing today, you'll be able to take back with you on this. All right, so next, it's time for a quick break. All right, welcome back, everybody. Hope everyone got to get some stretches in. I know I did, so we'll keep going along so we can wrap things up by 4 o'clock on time today. So next thing we're going to go into is, could this happen in your program? So, as previously mentioned, our spotlights have case studies included that can be used as staff training opportunities. We're going to go into 3 case studies that have been included in our medical emergency spotlight. These case studies include real scenarios that we have encountered in our work at the Justice Center, with names changed and any identifiable information removed. These case studies will include a narrative of what occurred during the incident and concerns noted from the case. These narratives that we will review today are shortened for the purpose of this training, and the entire case study can be found by accessing the spotlight as a whole off our website. So we're going to go ahead and jump into our first scenario. All right, so first we have James complained of stomach pain. James is a person receiving services. Lorene, a direct care staff, took his blood pressure and noted that it was high. Lorene called an RN, but did not tell the RN that James was also complaining of stomach pain. The RN directed Lorene to bring James to the emergency room. However, Lorene did not go immediately to the emergency room. While waiting for a cab, James collapsed. Lorene's first action after James collapsed was to call her supervisor. So, looking at the scenario, I think there's a couple standouts of things that might have gone wrong here. Firstly, Lorene did not communicate the stomach pain to the RN, which, was probably vital information that might have helped in her determining, whether he needed to go to the emergency room or not. In this case, she was already going to send him. So Lorene did not immediately bring James to the emergency room. Lorene called her supervisor instead of administering CPR. The expanded version of this case study does go in that the person was in cardiac arrest, so CPR was necessary. But in this case, Lorene did not perform that. And she did not call 911, instead called her supervisor, which is not to say that that isn't eventually who she should call, but in an emergency such as this, 911 was the better choice to begin with. Okay, so this is an example of some scenarios that you would see in our spotlights. We're going to go on to another here, and Tracy will go ahead and read that one for us, and we'll go through the concerns.
All right, thank you, Brandy. So in this scenario, we have Alana, who took Steve and Ian, both people receiving services, out in the agency vehicle to look at holiday lights in their neighborhood. Alana stopped at a drive-through on the way back to their IRA, to the home they lived in, to get everybody a snack. So she passed hot chocolate and cookies to Steve and Ian in the back seat. She did warn them that the drinks were hot and advised them to wait until the hot chocolate cooled off before they drank it. Steve began drinking his hot chocolate right away. He started coughing. Ian patted him on the back and reminded him to slow down. Now, when Alana looked in the rearview mirror, she noted that Steve was slumped over in his seat. His hand was on his throat. She felt that they were close to being back to the residence, to the IRA, so she kept driving. So like in Brandy's example, there are a couple of key concerns with this case scenario. The first one I think that everybody would recognize is that it appears as though Steve was having some sort of medical emergency in the back seat. Alana didn't see him eat a cookie, but maybe he had eaten the cookie with his hand on his throat. Perhaps he was choking. But instead of pulling over and calling 911, or pulling over and beginning life-saving interventions like giving abdominal thrusts, she continued to drive back to the IRA, so delaying him receiving medical care. Another concern that we noted from this scenario is that the people receiving services were provided food while in the vehicle, but Alana, who was driving, really wasn't able to provide supervision to the people while she was also driving. So that created an issue. A minor issue along with that is whether or not it was against agency policy for people to be eating or drinking in an agency vehicle. But again, a couple of key concerns here that led to a delay in Steve receiving medical care. So obviously, if we're encountering somebody who's slumped over, unresponsive, hands on their throat, we want to make sure that we call 911 and begin life-saving interventions immediately. Okay. So now I'm going to turn it back to Brandy to review another scenario.
Okay, so this will be our last scenario. And the reason we wanted to include this many was we found from feedback that the scenario seemed to be something that most agencies and those who have accessed our resources have found a lot of good things that they could take back to their staff and review at staff meetings, simple stuff to just go through to help, again, mentally prepare someone to say, what should we have done? What would we have done in this situation? What went wrong here? And it's just great to get good Q&A back and forth with staff. So just a PSA about that. So our next and last scenario, we have Georgiana, who was admitted to a youth inpatient psychiatric unit for depression. The unit nurse, Nancy, placed her on a 15-minute checks for safety. Georgiana began complaining of stomach cramps after her first night at the hospital. She did not eat breakfast. She did take her meds, which included clozapine, and went back to bed. The RN, Nancy, told staff that Georgiana had probably started menstruating and to just let her sleep it off. So staff did not check on her every 15 minutes as required. Georgiana went 35 minutes without being checked. When staff did check on her, they found her on the floor in her bathroom, writhing in pain from a bowel obstruction. So again, some concerns from this scenario. Firstly, we have Nancy told staff not to provide the 15-minute safety checks for Georgiana as required. These checks were in for safety, not necessarily for medical concern. So even if Georgiana was suffering from menstrual cramps, the safety check should have remained in place regardless. Nancy did not speak to Georgiana to confirm her hypothesis that Georgiana was having menstrual cramping or gather any additional information regarding symptoms that Georgiana may have been experiencing before removing the 15-minute checks. Again, they should have remained in place. And lastly, Georgiana was new to the inpatient unit, and due to the medication she was taking, the 15-minute check should have remained to ensure she was not experiencing any adverse effects to her medication, which with clozapine, one of those adverse effects can be stomach pain. So just a few things here that we would point out as needing some follow-up to avoid occurring again in the future. All right, so next, we are going to look at the final resource from our spotlight, which we wanted to highlight is the hierarchy of needs. I mentioned it earlier. We call it our medical emergency guidelines at a glance. And when discussing best practices related to the environment, this was the hierarchy poster that we felt would be good to have hanging up somewhere where staff are frequently coming in and out of. As you can see, it is color-coded. It provides a nice broken down system into 3 sections regarding when to call 911, when to go to the emergency department, and when to call the RN or the person's physician. And under each of these sections, you'll see some different examples of when you would want to call these different departments. Now, this chart is not set in stone. These were all things that through our experience we have found would warrant these type of calls. Your agency might add more, safer than sorry, that's up to you. But this was the guide that we wanted to provide for a jump off point that agencies could take and make their own and help staff to be able to respond quickly in these situations to prevent any, adverse outcomes. In the earlier poll, we saw that many of you have called 911 for medical emergencies. So this guide, we hope, will be a good resource for both yourselves and the staff and other people that you are working with. All right, so Tracy is going to wrap us up here.
Great, thank you. Davin, is there a question?
I just want to point out to people, the question came up, they love those guides, can we order them from the Justice Center? And it's all available for free on our website. You can just go right on and grab them for yourself. Mm-hmm. And that's the only question. I think you've done a great job.
Thank you. So at this time, we want to open it up to all of you to see if you have any questions for us about this Spotlight and Prevention Toolkit for responding to medical emergencies. If you do, feel free to use the chat, which we know that Davin is monitoring, to help us ensure that we answer any of the questions that you have.
There was a question if there's any resources for effective medical care, and yes, we just put up, that's our latest Spotlight on Prevention, so you can check that out on our website.
And we would like to mention with that one, we are trying a new format that instead of what we showed you today with the breakdown going through a PDF, we have this really neat flip book that I find is great to read through and much more
engaging.
Yeah. I was going to say fancy, but engaging is a better word, Davin. So thank you. So yeah, that's already available on our website. So
someone asked if there'd be any mock tests or an online training course on mock emergencies. So interesting suggestion. We'll look at that. I was hoping you would go over the emergency response chart. I guess more detail or...
Yeah, if there's something specific, we can go over more. I can back this up here. I'm just, sorry, let me make my page larger so I can read it better.
And I was just going to say, it can be hard to see right on the slide, but this is part of the toolkit that is available on the website.
Right, and it explains everything too. So this is not your only opportunity to see this. And then if you have questions, you can always reach out to the Justice Center, and we're happy to help you out.
Mm-hmm. And like I had said, how we sectioned these off was based on reports that we've received through our own work, through, discussions on what would warrant a 911 call, emergency call, but your agency can also, add in, move things around as they deem applicable.
Right.
Yeah.
Great. I'm just seeing a lot of thumbs up and
Yay.
compliments, so.
Great.
Well, what I would say then, if there are not a lot of questions, we would just like to remind everybody that these resources are all available, as Davin noted, for free on the Justice Center website. So this toolkit, in addition to the brand new toolkit for for effective medical care that you can look at following this presentation at your leisure. And if you have suggestions or ideas for prevention resources or topics that we can create or address, feel free to submit them to us at prevention@justicecenter.ny.gov. As Brandy mentioned, we're constantly updating and looking at our prevention resources to ensure that they're as current and germane as possible. We're always also looking at new topics that we can create to address any concerns from the field. If there are no other questions, then we just thank all of you for attending today, for your questions, for your participation in this webinar. Again, if you have suggestions for other topics, you can send them to us at the prevention mailbox that we just referenced. This will be available, the slides will be available Davin, you can give your spiel about that because I forgot where they're going to be available. I'm sorry.
I think they may be available later this week. We're hoping that after we conclude the investigation. And I just want to compliment this session's use of emojis. It's the most emoji use we've seen so far, so that's great. We love the feedback. Thank you. Let's give everybody 15 minutes back in their day. So, all right. Bye, everyone.
Thank you.
Thank you.